We have time for a few questions. While people are coming to the mic, I'll start with one. So we've seen some data on differences between races in adoption and some polling data on differences between races and endorsements. I'm wondering if the fact that the differences in the former seem to exceed the differences in the latter suggest anything about whether this is a disparity in access or a difference in preferences.
Could I answer that? I've been fascinated by the fact that, at least from once again Oregon, that the majority of people who want assisted death are well-educated people, minority groups, much less. I suspect that this, I'm sometimes tempted to say, is assisted death basically a form of boutique health care for the kind of 1% who want it, much as it was possible back in the way back for the well-to-do to get assisted death from their physician friends. And so I suspect there's a big class thing operating here, not to mention the personality difference of a lot of people can sin up to essential to different kinds of social and pressure. Other people can't.
Yeah, so I will say from my experience, what we've seen is that everybody dies, and people come and support this issue because they've experienced somebody in their life close to them who's had a death that didn't work. And it's about the consumer empowerment that comes with knowing that you get the prescription medication. So my guess is that the idea of I should get autonomy and control over the end of life is something that crosses all groups. And we know it's something that crosses all groups. And that actually for the palliative care community who's trying to figure out how do you get increased people to understand this, there's an opportunity. Like there's really an opportunity for you to embrace this as a way to help get greater acceptance. But that within the communities, the African Americans and Latinos, my guess is, and we don't have data, is that there is an access issue, that they're hitting up more roadblocks. There aren't enough doctors that they have access to, but we won't know that. That's part of what we'll hopefully gather through some data.
I would agree with that, and I think that more people ask for this program who have a relationship with the physician. And many people in the minority communities just don't have that relationship. So I think that's part of it. So it is access.
Great. Yeah. Thanks. It sort of pains me to have to say this, but I think the obvious has to be stated. A couple of weeks ago, there was an attempt to make this a bit more of a neutral space, but it has been obvious sitting here the last day and a half how weighted this is in terms of still of speakers who are in favor of legalizing assisted suicide. In particular, that there are 4 members of Compassion and Choices, spokespersons for that on the program, including adding one in the middle of the night to this session, is, I think, something that we have to look at if we were to declare this, as it was said, to be a neutral space in which we are looking at the data rather than a lobbying effort. I just think it needs to be stated for the record because it seems obvious to anyone coming from Mars what's happened here. Thank you.
Can I just clarify? I just want to clarify that. I am actually the only spokesperson from Compassion and Choices who is here. There are other people here who may actually be advocates who endorse the law, but I am the only spokesperson from Compassion and Choices who's here.
Well, Dan Diaz, who began, states on his record that he's a spokesperson for Compassion and Choices on behalf of this. Dr. Reagan has been a spokesperson on behalf of the organization, and Omega Silva identified herself as a spokesperson on behalf of the organization. So they're maybe not paid as spokespersons, but they're closely affiliated, and I think that that's troubling. That's troubling to somebody who's looking at this from the outside as a neutral space.
May I just intersperse, because I have many problems with compassionate choices, but I will note that there are no organizations opposed to assisted death that are quite as well organized and carry as many people as that compassionate death. It's not surprising that they dominate this meeting, because they'll dominate most meetings because they have a great deal of clout.
Do you think that it's because the majority of people in the United States and the majority of physicians actually think that this is a good program, so that you don't have an equal division of people who are against it versus people who are for it?
Okay, we'll treat that as a provocative, rhetorical question. We do have time for one more. I think we're over there.
You've been deprived 3 times, I think, so go ahead.
It's for Daniel Callahan. This is Michael Strauss, and I have questions for you about your trying to connect the law in Oregon with the suicide rate. This has been a particular question of mine for quite a while, and I think you're showing some spurious correlation. There are 2 sets of data that suggest there is no correlation between the implementation of the law in Oregon and the increase in the suicide rate. The first set of data, I just went and got them from the CDC last year, and you can't see the graph. I have it on my computer. I'll show it to anybody here, and I'll email it to you. But there are 3 parallel curves on a graph I've developed. They show the suicide rate in Oregon, which is a little higher than the suicide rate in Washington State, which is a little higher than the national rate. But all 3 curves come down nicely from the 1980s to about 2001, and they go up again. So we don't know why the rate has gone up since around 1988 or 2000, but it's gone up all across the country. The second point is there was a peer-reviewed journal article in the Southern Medical Journal about 1.5 years ago that looked at this very question, and those researchers could not find a statistically significant difference in the suicide rate based on implementation of the law in Oregon. So I don't know, you did make that connection in your remarks. I don't know if you have any other data to address the suicide rate.
Yes, I recently published an article, in fact, in the Southern Medical Journal with a colleague in which we specifically present data on that. And interestingly, the data came from earlier articles in the Southern Journal of Medicine, showing a very clear correlation and showing some statistics and how particularly there's the correlation with the high correlation among the elderly as well with suicide rates. So.
Great. I think we're going to wrap this up.
I understand that article is going to be distributed, so I do recommend it, even though it's my article. But nonetheless, it's a good article.
Dr. Halpern.
It has been distributed. If it hasn't, we'll make sure to send it to everyone.
Dr. Halpern, my name is John Kelly, and I'm from Not Dead Yet. And I'd just like to respond to Daniel Callahan saying that it's natural for Compassion and Choices and proponents to dominate this meeting because they have so much clout. They have so much clout because they're from a powerful social class which is united in pushing for this. Disability rights advocates are very well organized, but we don't have the resources or the funding or the institutional support to get our points across. Meanwhile, I would ask Compassion and Choices to stop acting as if agonizing pain is the leading reason that people request assisted suicide. And when you do admit the reality that it's all about disabling issues, please don't imply that our lives living with disabilities are somehow less worth living, as Daniel Callahan pointed out. The use of the word dignity is a way to separate people based on quality of life into who should live and who should die.
Thank you.